Gabapentin is a medication commonly prescribed for seizures and nerve pain. It is generally considered safe and well tolerated. However, misuse and overdose cases have been on the rise. While not as inherently lethal as opioids, gabapentin overdose can have serious consequences, especially when combined with other substances. This is particularly true when combined with central nervous system depressants. These can include alcohol, benzodiazepines, and opioids. This report will delve into the critical management of gabapentin overdose, focusing on acute care and intensive care unit (ICU) considerations. Gabapentin works by affecting the way nerve signals travel in the brain. This can reduce seizure activity and alleviate nerve pain. It is often used to treat conditions like epilepsy, post-herpetic neuralgia, and diabetic neuropathy. Gabapentin is available by prescription only and comes in various forms, including tablets, capsules, and oral solutions. It is crucial to take gabapentin only as prescribed by a healthcare professional. The toxic dose of gabapentin is over 35,000 milligrams or more than 18 milligrams per kilogram. Overdose on gabapentin can lead to a range of symptoms. These can vary in severity depending on the amount ingested, individual factors, and the presence of co-ingestants. Common symptoms of gabapentin overdose include drowsiness, dizziness, drowsiness, ataxia, slurred speech, nystagmus, movement disorders, and gastrointestinal upset. In more severe cases, individuals may experience respiratory depression, coma, hypotension, drowsiness, and eosinophilic pneumonia. Recognizing the signs and symptoms of gabapentin overdose is crucial for prompt medical intervention. If you suspect someone has overdosed on gabapentin, immediately call emergency medical services. Provide them with as much information as possible, including the patient's age, weight, any known medical conditions, and the approximate time and amount of gabapentin ingested. A 54-year-old male presented to the emergency department with a suspected gabapentin overdose. The patient admitted to ingesting 9,200 milligram gabapentin capsules, totaling 18,000 milligrams, along with 5 clonazepam tablets the previous day. Initially, he was alert and responsive. However, his condition deteriorated, and he became increasingly drowsy and less interactive. Upon arrival at the emergency department, the patient's vital signs were blood pressure 136 over 97 millimeters of mercury, heart rate 120 beats per minute, respiratory rate 17 breaths per minute, and oxygen saturation 98% on room air. Despite the initial stable vital signs, his mental status continued to decline. This raised concerns about potential respiratory compromise. Due to his worsening condition, the decision was made to intubate the patient for airway protection. He was placed on mechanical ventilation to assist his breathing. After intubation, his vital signs were blood pressure 96 over 67 millimeters of mercury, heart rate 75 beats per minute, and oxygen saturation 100% on 42% FiO2. His temperature was 95.36 degrees Fahrenheit, rectal core measurement. The patient was immediately transferred to the ICU for close monitoring and management. His overdose was considered severe, given the dosage ingested and his clinical presentation. The co-ingestion of clonazepam, a benzodiazepine, was a significant concern as it likely potentiated the central nervous system and respiratory depression caused by the gabapentin. Initial laboratory results were significant for a positive urine drug screen for THC, benzodiazepines, and cocaine. This highlighted the complexity of polysubstance abuse and the need for comprehensive toxicology screening in overdose cases. Importantly, his electrocardiogram showed a prolonged corrected QT interval of 483 milliseconds. Intravenous magnesium sulfate was administered to address the prolonged QTc interval. Intravenous potassium supplementation was also provided to further mitigate this risk. To manage his pain and agitation, he received intravenous fentanyl and midazolam for sedation. The patient's hypotension, following intubation, was managed with intravenous fluid boluses. Treatment of gabapentin exposure is largely supportive, with careful attention to airway protection in severe cases. Hypotension is usually mild, and it responds to intravenous fluid boluses. If hypotension persists, administer dopamine or norepinephrine. Admit all severely symptomatic patients. Treat seizures with IV benzodiazepines or barbiturates. This case illustrates several crucial aspects of gabapentin overdose management. Firstly, it underscores the significance of supportive care. This includes airway management, hemodynamic support, and close monitoring for potential complications. Secondly, it highlights the dangers of co-ingestion, as seen with clonazepam in this case. Co-ingestants can significantly complicate the clinical picture and must always be considered when managing overdose cases. The case also emphasizes the importance of a multidisciplinary approach. This includes emergency medicine physicians, intensivists, nurses, pharmacists, and respiratory therapists, all working together to provide comprehensive care. Lastly, the patient's history of polysubstance abuse and intentional overdose underscores the need for a psychiatric evaluation. This is crucial to address any underlying mental health issues and reduce the risk of future overdoses. In conclusion, while gabapentin is generally considered a safe medication, overdose can lead to significant morbidity and even mortality. Prompt recognition, aggressive supportive care, and a comprehensive approach to management are crucial for improving patient outcomes in gabapentin overdose cases. Early involvement of a poison control center can be invaluable in guiding management decisions. Visit medicaltoxic.com for more insightful case studies and resources in medical toxicology. Stay informed and take care.